Hello, welcome to the week we talk about sex therapy and the PLISSIT model and applied couples and relational therapy, CFT 5103 here at Antioch University. Our objectives are to describe the role of sex therapy within couples and relational therapy practice, including the role of ASECT as a professional organization, describe the goal, scope, and therapeutic role of sex therapy in supporting sexual health, intimacy, and relational well-being, identify common sex therapy models and interventions used to support intimacy, sexual well-being, and relational functioning. And we're going to explain the implicit and the explicit models and their application in addressing sexual concerns within relational therapy settings. So we start off with sex therapy, our scope of practice, and our clinical competence. We want to be very clear that avoiding conversations about sexuality can unintentionally reinforce shame, stigma, avoidance, and relational distress for clients. I absolutely have talked to LMFTs, relational therapists, who were very uncomfortable with the idea of talking about sex and sexuality. And while that's fair in the culture that we're in, it is maybe something that we need to be working on, right? Like we talk all the time about self-therapist, things that we as therapists need to work on so that we can work with those effectively in therapeutic settings. And if we are doing relational therapy that includes partners and couples, and maybe just adults who enjoy or decide that they would like to have sex, this is something that we should be willing to talk about, since that's going to be a significant part of folks' lives and how they interact with the world and things that affect them in their lives. So being uncomfortable or unwilling to have those conversations in relational therapy contexts, and even I would argue individual therapy contexts, is not the best thing, right? On top of that, if this is a CFT program, this is a program that is preparing you to practice as a licensed marriage and family therapist eventually, and in all states but Florida currently, that means that you have competency to practice sex therapy. In Florida, you need an additional training and certification for that. In all the other states, being a marriage and family therapist means that it is within your scope of practice to practice sex therapy. So, sex therapy and sexuality related clinical work are generally considered within the scope of practice for the American Association for Marriage and Family Therapists. So, you all trained LMFTs, or who will be trained LMFTs, in every state except for Florida. In Florida, we need a specialized certification or additional credentialing to practice sex therapy. And this may change, right? Like this is just me talking right now in June of 2026. This may change. So always make sure you're staying up with your own state's laws where you're practicing, in the states where you're practicing. Sexual concerns frequently emerge in couples and relational therapy. Even when they're not a presenting concern, it's going to come up. People are going to talk about it. It's a big part of their lives, right? And so not being able to talk about it or not being able to welcome that conversation can be a problem. And we don't need to be certified sex therapists, right? Like if anyone wants to be a certified sex therapist or like wants to work towards that, absolutely. I would love for you to send me an email. Let's talk, especially if I'm your advisor. Let's talk about the sex therapy certificate here at Antioch. I'm more than happy to help you make decisions around that. Even if I'm not your advisor, I'm still more than happy to talk about that. I teach in that certificate as well. But even without that certificate, you don't need to have a special certificate in sex therapy. You do not need to be certified sex therapist through ASECT to discuss sexuality, to discuss physical intimacy, to discuss consent, to discuss desire, or discuss like relational sexual concerns. These are all things that are within your competence as somebody who has been trained as a marriage and family therapist in a COEMT accredited university. That said, competence does require appropriate education, self-awareness, right? That's self-therapist stuff, cultural responsiveness, ethical practice, supervision, and a willingness to refer out when concerns exceed your therapist's training or scope. And in fact, we'll talk about the fact that that is part, I was about to say an explicit part. I guess that is correct. It is an explicit part of the implicit model and explicit model. So I want to take just a moment to introduce ASECT. ASECT is AASECT, but almost everybody just calls it ASECT. This is so sort of like AAMFT, right? Is the American Association of Marriage and Family Therapists, and that's kind of the governing organization for marriage and family therapists. ASECT is the American Association of Sexual Educators, Counselors, and Therapists, ASECT, and it is the kind of like professional governing professional organization that focuses on sexual health, sexuality education, sex therapy, sex counseling, all of that sort of stuff. So this includes providing training standards, ethical guidelines, professional certification processes for sexuality professionals. All of that falls within the scope. So just like for becoming an LMFT, you're having to meet these like standards that have been set forth by AAMFT, and CLAMFT to become a certified sex therapist. We need to meet standards set forth by ASECT. ASECT very clearly promotes culturally responsive, evidence-informed, non-judgmental approaches to sex health and relational well-being. It recognizes that sexuality is a normal and important aspect of human development, identity, intimacy, relationships, and establishes those competencies. It also has incorporated in like gender in with sexuality. So it also is a place that you can go for like trainings and information around like gender validating concepts, right? Which is something that we are still working towards, I think, in some other professional aspects. So we established competencies there related to ethics, diversity, communication, sexual functioning, relational systems, and professional practice. They're really kind of the professional organization over all that. And they're just a good thing to like know exists and know about, even if you're not going to go on and, do the sex therapy graduate certificate and look to become a certified sex therapist. But certainly for this conversation. So if you are interested in becoming an ASECT certified sex therapist, I want to just take a second to talk about what that looks like. So again, ASECT certification reflects advanced specialization in sexuality related clinical work beyond the general psychotherapy training, including beyond the relational psychotherapy training, right? They require like a qualifying graduate clinical degree with a professional license. So that's going to be your, LMFT, LPC, LCSW, psychologist, physician, all of those. You have to have completed specialized sexuality education and therapy training through approved coursework and continuing education, like our certified sex therapy program here at Antioch, but there are other ways to do it as well. It requires at least 50 hours and 18 months of supervision of clinical experience addressing sexual health and sexuality related concerns with a ASECT approved supervisor. Requires a minimum of 300 client therapy contact hours providing ASECT qualified sex therapy. And it also requires that you are a member of ASECT and adhere to the ASECT ethical standards and ongoing professional development. So none of that should sound terribly different. I mean, it's a little bit less than like what you have to do to get your LMFT, right? But it can be less because it assumes you've already done a lot of work getting your LMFT. But like that shouldn't sound like very weird because you will have gone through similar processes both as a graduate student to finish your graduate degree, and then you'll go through a similar process again as like an associate or temporary, depending on what state you're in and what they call it, therapist, or therapist in training. So this shouldn't be too big of a surprise, but I just want to make sure that we knew what this was before we moved into talking a little bit more about sex therapy. So moving on to sex therapy, we're going to be talking about like modern sex therapy, which integrates behavioral, relational, developmental, psychological, and systemic, our field, right, understandings of sex and intimacy. So, sex therapy is not only about dysfunction or symptom reduction. Sex therapy is also about helping clients develop safer, more connected, and more fulfilling sexual and relational experiences. I have clients all the time that, like, there's nothing really wrong, but maybe we've just never gotten to really explore things or really figure out what we enjoy or we like. And that's sex therapy too, right? Sex therapy is not just about like what's wrong, although we'll talk about that a little bit, but it also is about just like the positivity of getting to be a fully like actualized sexual human being, right? If you so desire. So, what is sex therapy? It's a specialized therapeutic approach focused on concerns related to sexuality, intimacy, sexual functioning, pleasure, and relational connections. It can involve individuals, so just one person, right? Both as who you're working with, but also like sex can just be one person. It can involve couples and it can involve relational systems. So we're talking like you might have a family you're seeing and something comes up with the parents or even maybe the kids or something's going on, right? Depending on age groups and what's going on, we might be more or less concerned about that. But we can also talk about like polyamory and, other forms of relations rather than what we consider the most mainstream options. Addresses sexual concerns within emotional, relational, cultural, developmental, and systemic contexts. Often integrates relational therapy models, communication work, psychoeducation, mindfulness, behavioral interventions, and trauma-informed approaches. And focuses on reducing shame. So we want to increase sexual well-being and support healthier relational and sexual experiences. Our key figures are William Masters, Virginia Johnson, Helen Singer Kaplan, Emily Nagoski. And these are not it. These are just some that I picked out. There are definitely more key figures, but we don't have the time to go over everybody when it comes to this. So I just picked out a few. Please, if you're interested in this, look more into it because there are so many amazing folks that have led the sex therapy field to where it is now. So William Masters kind of co-pioneered modern sex therapy and human sexuality research, studied physiological sexual responses and sexual functioning, and co-developed behavioral interventions around sexual concerns. Virginia Johnson collaborated with Masters in foundational sexual research, helped develop sensate focus with couples and couples-based sex therapy interventions, and emphasized communication, intimacy, and reducing performance anxiety, which was a big deal at the time. I mean, it's still a big deal, but big deal. So Helen Singer Kaplan integrated psychodynamic and behavior approaches into sex therapy, developed the triphasic model of desire, arousal, and orgasm, an expanded understanding of emotional and relational influences on sexuality. Emily Nagoski contributed contemporary work on sexual desire and contextual sexuality, popularized concerns such as responsive desire and the dual control model, and emphasizes the influence of stress, relationships, and emotional safety on sexuality. So if we move from key figures to like diagnostics around sexual dysfunctions, we have kind of a list here. Those of you who were in my psychopathology 1 course know how I feel about these diagnoses. And that said, like these are changing all the time, right? So none of these are perfect. None of these are necessarily like the end all be all. We just kind of do our best with them. So the sexual dysfunction conditions you may see per the current DSM-5 is delayed ejaculation, erectile disorder, female orgasmic disorder, female sexual interest arousal disorder, genitopelvic pain penetration disorder, male hypoactive sexual desire disorder, premature or early ejaculation, substance medication-induced sexual dysfunction, other specified sexual dysfunction, and unspecified sexual dysfunction. So just as a quick reminder, there are, since we're talking about, being sex therapists or being sex informed therapists. There are some things that aren't great about some of these when we are discussing working with like trans and genderqueer folks. The current disorder is a female sexual interest arousal disorder and male hypoactive sexual desire disorder. Kind of took a step backward from the DSM-4, which had a more gender inclusive version of these disorders and separated them out. So I would be really transparent about these disorders when we're diagnosing them. And I would be like working with the person to make sure that we're not diagnosing someone with something that doesn't actually fit their gender, or fit like their identity. They were just being really, really like conscious of those sort of things when it comes to diagnosing with these disorders. So the role of a sex therapist. Sex therapists help clients explore sexuality and intimacy in ways that promote safety, connection, self-understanding, and relational well-being. We want to create a safe, non-judgmental space for discussing sexuality, intimacy, pleasure, and relational concerns. We want to help clients reduce shame, anxiety, avoidance, and stigma related to sexual experiences and identities. We want to assess biological, psychological, relational, cultural, and systemic factors influencing sexual well-being. We want to support clients in improving communication, emotional connection, consent, and sexual satisfaction. We want to provide sexual psychoeducation, interventions, and referrals that are within the therapist's scope of competence. So I think that psychoeducation piece is really important here because, and we'll talk about this a little bit later as well. We live in a culture, at least if you're watching this from the United States, we live in a like societal culture that is very uncomfortable with sex, but still uses sex to do all sorts of things, to sell things, to promote things, to do whatever, but is really uncomfortable with sex. And our education systems show that. So I used to teach a undergraduate child development course. And the first year I taught it, I was in the week where we were talking about like conception and stuff like that. And I kind of just like briefly said something about ectopic pregnancies, and I just saw like blank faces. And I've got like 30 students, and they're almost all female presenting. And I stopped for a second. Something made me stop, and I asked like, who knows what an ectopic pregnancy is? And two of the 30 students raised their hands. And these were undergraduate students. These were adults who didn't know what ectopic pregnancies were and didn't know how dangerous they were. So we took a little bit detour and like discussed a few different like ways that conception happens and how they can result and like what those numbers are. But I've always kind of had to sit with that we have done an extremely poor job of educating folks around topics of sex and the results of sex and just like general education around sex and sexuality. So as a therapist, one of the things that will hopefully be within your wheelhouse to do, and that hopefully you have training for and you have education for, is to explain some very basic things about sex. And do it in a way that doesn't make people feel silly or stupid, or like they should already know, because they may already feel that shame. They may already feel really embarrassed, right? And we want to make it really, really just well, of course, we want you to know this, and well, of course, you didn't already know this, right? So that's just a real quick note that the psychoeducation piece might be a big piece for some of your clients. And if that's a big piece for you, that's okay. I would just really encourage you to start seeking out some of that education around sex and how sex works and what sex is and the results of sex from, STDs through pregnancy and everything in between. And then we want to maintain culturally responsive, trauma-informed, and ethically grounded approaches to sexual health discussions, because all of this is going to be going on, right? We're going to have cultural pieces with sexuality and sexual experiences. We're going to have trauma pieces with sex and sexual experiences. And so we want to be mindful of that. It's important for therapists to respect clients' self-determined therapeutic goals and recognize that cultural, religious, and other values may meaningfully shape how clients understand sexuality and intimacy. I was in an ASECT supervision with my ASECT supervisor, and it was a group supervision, and somebody else was just talking about how they had a couple that was from a different culture than they were from, and how they were like being very mindful of like sticking to that couple's goals as a result. And the supervisor kind of stopped it and was like, I'm so glad you're doing that because that's something that like folks sometimes really struggle with. And the other therapist was like, wow, you know, that's what I should be doing. I should be respecting them. And I absolutely agree. And that again, maybe some like self of the therapist stuff. There may be things that like are culturally different from your culture. There may be things that just don't make sense to you, and that's okay. We still need to respect our clients' like self-determined goals, and work with them. And if we're not able, we need to, refer out to somebody who can. But my hope would be that you've done yourself the therapist stuff and that you will be able to do those things. So, cultural competence in sex therapy. Sex therapy is most effective when therapists understand sexuality within the broader cultural, relational, and systemic context of the client's lives. Sexuality is shaped by culture, by religion, by family systems, by community values, by gender norms, and social contexts. Clients may hold very different beliefs about intimacy, pleasure, consent, monogamy, communication, gender roles, and sexual expression from you, from each other, just from what you expect. Experiences of stigma, discrimination, trauma, oppression, or marginalization can significantly impact sexual well-being and relational functioning. Therapists should avoid assuming that our own sexual values, comfort levels, or relational norms are universal. And we want to like work to be culturally responsive, culturally humble around sex therapy, being, curious, humility, affirmation, and just doing that ongoing self-reflection and self of the therapist work. Sometimes when cultural competence may arise in sexual therapy, there's can be differences in cultural religious beliefs about sexuality, gender relationships, and we may have really strong feelings sometimes about those beliefs. We may have really strong feelings about those cultural choices or religious choices. And we just have to remind ourselves that those aren't our choices, right? As long as everybody's a consenting adult and we're not looking at non-situational coercive control or IPB or anything like that. Like it is not our choice how folks choose to interact sexually or through their gender or through their relationships. There may be shame, guilt, or anxiety connected to sexual experiences or desires. We may see conflicts around monogamy, consensual non-monogamy, kink, or sexual expectations. We've got LGBTQIA and GSERD related experiences. So we may be looking at, the need for understanding identity exploration and minority stress. There may be body image things, disability, chronic illness, aging, or reproductive experiences that we need to be culturally competent around. And we may have trauma histories. There may be sexual abuse, sexual molestation, and just general experiences of like sexual stigma, discrimination, and even things like sexual assault are all unfortunately very, very common. And then intercultural relationships or differing relational expectations between partners may come up. And this is actually something I see fairly often where folks are coming from different cultures, and I don't just mean like sometimes I mean like different ethnic cultures, right? And that's the thing too. But sometimes it can be surprising, like just a difference in maybe coming from like poverty versus middle class, or a difference from growing up in the rural Midwest versus on the northern East Coast. So sometimes those cultural differences can surprise us. Or sometimes people could have grown up really close together, but there's just still cultural differences based on the families they grew up in and how things were handled. And culture, it may and likely will impact the client's goal for sex therapy, and we need to be respectful of that. So I just want you to take a moment. You can pause the video, but take a moment to think about how might cultural values influence what sexual related experiences clients feel comfortable or uncomfortable discussing in therapy. Maybe also take a moment to think about what is true for you discussing and what that might mean about the type of self-therapist stuff that you need to do. So we're going to move forward to talking about sex therapy and models and frameworks. We are not going to talk about every sex therapy model and framework that exists. I just have a variety of them we're going to talk about. But again, please, if you're interested in this, and even if you're not, maybe just take a second to like look through and do some of your own research on what other models are out there and what might work for you for working with sex therapy. So I'm going to start with sensate focused therapy. So if we go back to William Masters and Virginia Johnson, this is like their therapy. It's a behavioral and mindfulness oriented approach using structured touch exercises to reduce anxiety and increase connection and attunement. The model encourages clients to focus on sensory experience and emotion and emotional presence rather than performance or outcome, right? Remember, we're trying to reduce the anxiety around performance. We've got William Masters and Virginia Johnson, who pioneered this modern behavioral sex therapy and developed the sensate focused interventions. This is often used for anxiety, desire concerns, erectile difficulties, orgasm concerns, and relational disconnection, where we're trying to like reconnect, right? We'll also see this has been integrated into some other models. So cognitive behavioral sex therapy, CBST, is a cognitive behavioral approach focused on changing unhelpful thoughts, emotional responses, and behaviors related to sexuality and intimacy. It examines how beliefs, anxiety, avoidance, and learned patterns influence sexual experiences. This really draws from the broader cognitive behavioral therapy traditions and applications to sex health and functioning. So it doesn't have, I was about to say it doesn't have any like specific key figures. It might just be it has too many key figures for me to like name everybody here. But you can find quite a bit of research on this. And then again, it's frequently used for shame, anxiety, performance concerns, and avoidance patterns. We've got psychodynamic sex therapy. This is a psychodynamic approach that explores unconscious processes, attachment experiences, and relational dynamic influence on sexuality. The model examines how past emotional experiences and internal conflicts shape present sexual functioning, intimacy. Our key figures for this is Helen Singer Kaplan, and this who integrated psychodynamic and behavioral concepts into this modern sex therapy practice. And then this focuses on emotional meaning, attachment, vulnerability, and relational dynamics within sexuality. Then we have integrative sex and couples therapy, ISCT. This is an integrated approach combining sex therapy, attachment therapy, and couples therapy to address sexuality within relational systems. This model conceptualizes sexual concerns as connected to broader emotional developmental and relational dynamics. So we have already had residency, and we've already had our lecture around imago therapy. And then we just talked about sensate focus therapy back here. So two big pieces that are integrated into this model are imago and sensate, along with some others, but those are kind of two of the bigger pieces of this. So if you already have like been doing some of that imago therapy in like your role plays and stuff like that, and going, you know what, this feels okay. I can do the imago relation therapy. And if when you were listening to like the little blurb about sensate therapy, which is like, about sensual touching and just enjoying touch, then this might be a good model for you for sex therapy. I am biased. This is the first sex therapy model I learned when I realized I needed some sort of sex therapy model to use with clients, and that I hadn't gotten that from my own master's program. And my master's program didn't have options for like a sex therapy certificate, so I wasn't able to like go take classes around sex therapy. I went out and found training, and the trainings I took were Tammy Nelson's trainings on integrative sex and couples therapy. So I'm a little biased here, but I think it's a good model to use. It's frequently used for desire discrepancy, infidelity, erotic disconnection, and like long-term relational change. So I've used this a lot when there, has been betrayal of infidelity, and also things like lesbian bed death and stuff like that for like reconnecting. Mindfulness-based sex therapy. So this is an approach that uses mindfulness practices to increase present moment awareness, bodily attunement, and sexual connection. The model helps clients reduce distraction, anxiety, and judgment while increasing awareness of physical and emotional experience. Key figures are Lori Brotto, who contributed major work to integrating mindfulness into contemporary sex therapy practice, although there are others. And then this is often used for desire, arousal, orgasm, pain concerns, and anxiety-related sexual difficulties. And then this is less an actual model and more like an approach concept. But these systemic approaches to sex therapy, right? So this is a relational approach that examines sexual concerns within the broader context of couple, family, and social systems. The focus is on interactional patterns, communication, roles, boundaries, and the ways that relationships influence sexual functioning satisfaction. There's been many different people who've published around systemic therapy techniques and approaches to sex therapy, but this really examines how relational patterns, family influences, social context contribute to sexual concerns and strains. And then we have a narrative approach to sex therapy, which you will also see called narrative sex therapy. If you're looking it up or wanting to look more into it, I would go to like Google Scholar and look both for narrative sex therapy and narrative approach to sex therapy. This is a postmodern approach that focuses on stories people tell themselves about relationships, sexuality, and identity. Problems are viewed as separate from the person, so we externalize things a lot. And therapy explores how dominant cultural messages, shame narratives, and personal meanings influence sexual experiences and relationships. Many folks have published on this. And then this helps clients kind of reauthor our sexual narratives that have become constrained by shame, stigma, or limiting beliefs, which quite a lot of concerns, or just the lack of exploration or like really like actualization in our sexuality comes from limiting beliefs. And then the PLISSIT and explicit frameworks, which we will talk about more in depth than any of these others, here in just a moment. The PLISSIT framework is a structured, these are both structured frameworks that help clinicians address sexual concerns through permission giving, psychoeducation, intervention, and referral. And then the explicit expansion of the PLISSIT model emphasizes ongoing permission, reflection, and cultural responsiveness throughout therapy. Jack Anand developed the PLISSIT model, and then Sally Davis and Bridget Taylor expanded that to the explicit model. This is widely used by relational and healthcare professionals working within their scope of competence around sexuality. So moving on from that to the PLISSIT model. The PLISSIT model provides clinicians with a structural and accessible approach to addressing sexual concerns within their level of competence. And so this provides a structural and accessible framework for responding to sexual concerns without needing to function as specialized sex therapists in each case. So just kind of repeating that's within the level of competence, kind of lets you take it from where you are. So if you're not planning to be a sex-focused therapist, this is a really good model for you, right? Now, if you want to be a sex therapist, like we can talk about other models as well. But if you're planning to focus on something else, but you know sex is going to come up, because it will, this is a good model for you. So what is the PLISSIT model? It's a clinical framework developed by Jack Anand for addressing sexual concerns in therapeutic and healthcare settings. It helps clinicians respond to sexual concerns within their scope of competence. It organizes intervention into 4 levels. So permission, limited information, specific suggestions, and intensive therapy. It emphasizes normalization of psychoeducation, communication, and appropriate referral when needed. It encourages therapists to approach sexuality with openness, comfort, and non-judgment, and to like feel like you can handle this, right? So a big goal of the PLISSIT model is to be able to like take a breath and be like, okay, I got this, instead of just as a care provider freezing up and feeling like you're out of your depth. So Jack Anand, our key figure here is Jack Anand, who developed the PLISSIT model in 1976. This created a structured framework for discussing sexual concerns within healthcare and therapy settings because that was lacking and was a problem. It emphasizes permission giving, psychoeducation, and scope of practice, and really helped to normalize conversations about sexuality in clinical work, both, mental health clinical work and also physical health clinical work. So the PLISSIT model spells out, it's an acronym, it spells out permission, limited information, specific suggestions, and intensive therapy. And that spells out PLISSIT. This is just another little infographic around it. So permission is that we give clients permission to discuss sexual issues. And I would also argue that we should be asking clients permission to discuss sexual issues. That we recognize clients may be uninformed about sexual issues. And so we provide limited information that is helpful and not overwhelming. So we don't want to just like tell them everything because that's going to be overwhelming, right? So instead, we want to provide limited information that is helpful for what they're dealing with right now and that provides the information that they can use and work with. We want to make specific suggestions. Again, we don't want to be like overwhelming. We don't want to like get too far into the weeds. We want to make specific suggestions based on our full evaluation of the patient's presenting problem or problems. And we want to refer the client to the appropriate intensive therapies. So again, staying within our scope of care, if what the client is presenting with is not something that we can work with, if I'm not a trauma therapist, I have a client in front of me who, is dealing with trauma around sexual assault or something like that, my best option is to refer out to somebody who specializes in that. So we want to refer clients to appropriate intensive therapies, including mental or physical healthcare providers or providers of specific treatment types like trauma, sex therapy, biomedical. So PLISSIT model for addressing sexual functioning and concerns. And you will have access to all these slides. And then if we move forward to the explicit model, so remember this is the expanded PLISSIT model, the explicit model reframes sexual health discussions as ongoing relational and culturally informed therapeutic processes. So it takes the PLISSIT model, which is fabulous, and it just adds on a little bit to it that there was maybe a piece that was missing or was not made explicit. And now they're making it explicit with the explicit model. I think it's a fantastic naming convention. So the explicit model reframes sexual health conversations as ongoing relational and culturally informed processes rather than a linear intervention sequence. So with the PLISSIT model, we run the risk of going, okay, we gave clients permission to discuss sexual issues. Great, checkbox, right? And I recognize that they may be informed. So I provided the limited information that's helpful and not overwhelming. And they made some specific, checkbox. And I made some specific suggestions based on my evaluation, checkbox. And I referred them out to intensive therapies that are outside my scope, checkbox, right? This runs the risk of having this like linear list that I'm checking off. And then once I've done that, I'm done. I've done what I'm supposed to do and I'm never going to do it again. And so we just want to like take a breath, be like, okay, so just because I talked to my client once doesn't mean they stopped having sex. It doesn't mean that this is never a thing again and that this is an ongoing thing. So expanding it rather than seeing it as this linear intervention sequence that we do once and then we don't have to touch again. So our key figures are Sally Davis, who expanded the PLISSIT model into the explicit model, emphasized that ongoing permission giving throughout the therapeutic process, highlighted therapist self-awareness and reflective practices in sexual health conversations, which we should all be doing, right? Self as a therapist. And then we also have Bridget Taylor, who contributed to the development and application of the explicit model, helped expand culturally responsive and client-centered approaches to sexual health discussions, and emphasized collaborative and relational approaches to sexual well-being. So what is the explicit model? is an expanded version of the PLISSIT model developed by Sally Davis and Bridget Taylor. It emphasizes that permission giving should occur throughout the therapeutic process rather than only as an initial step. So that we should be continuing to bring up sex and give clients the option of bringing up sex and giving them permission to bring up sex, right? We live in a culture where talking about sex often is not okay. And the ways that we do talk about sex are not always the healthiest, right? And the ways that sex is displayed in our culture are not always the healthiest. So permission to talk about everyday sex or sex things that that person is experiencing, whether good or bad, encourages ongoing reflection, cultural humility, and attention to self of the therapist and therapist self-awareness, highlights the importance of creating safety for conversations about sexuality, identity, intimacy, pleasure, and shame, and supports collaborative, client-centered, and culturally responsive approaches to sexual health discussions. This is the expanded PLISSIT model for addressing sexual functioning and concerns. So you can see the PLISSIT is still here, PLISSIT. So we still have that. And here that at the center of it all is permission giving, and that we're going to constantly reflect and review around that. And then we still provide information about the impact of stoma on sexuality, myths, altered body image, the expectations is for this example they're using. We're going to review and reflect on this as we go. We're going to address individuals, so specific suggestions address individual issues according to sexual history. Is opportune to encourage the exploration of body image and the different ways of expressing sexuality. And then IT, we're going to refer to a specialist for intervention, so psychologist, urologist, psychosexual therapist. And the whole way we're going to be doing this reflection and reviewing of all of this. And we can see this self-awareness, reflect, review, knowledge, challenge assumptions. We're going to keep doing it over and over and over. So as a final reflection, I'd love for you to think for a moment about how do you currently feel about discussing and addressing sexuality and intimacy in therapy with a client. How did you feel before this video? How do you feel now? What do you need to seek out about doing your own self with a therapist stuff? What are you going to be good at with it? What do you think that you probably are going to be doing okay with? And what do you maybe need to do some reflection and reviewing on yourself around, right? Because none of us are perfect and we all have those things. But otherwise, let me know if you have any questions, and I will see you in class.